Hi everyone, this is Staff Sergeant Matthews and this brief is about our unit's medical service mission. This will be all about what UTCs or unit type codes are. I know not a lot of people know about them, what they are, how many we have in our unit, and how each one is specific to the mission, so I'll be talking about that, as well as our mission during peacetime and wartime. I'll be bringing up some deployment experiences regarding how the UTCs really fit into the mission to give everyone an idea of what it looks like in real life. The mission statement for medical services is shown here. Our mission is to enable medically fit forces, provide expeditionary medics, and improve the health of all we serve to meet our nation's needs. And that obviously fits into the Air Force mission as a whole, because we make sure that our members here at the 934th Airlift Wing are always mission ready and capable. Our unit's peacetime mission is to train our unit members to ensure wartime mission capability. We also support the physical examination process, which is what we're doing on drill weekends as we're seeing members all across the base to make sure that they're green and good to go in their medical readiness. Our wartime mission is to provide manpower to support the en route patient staging facility, or the ERPS. Here are some UTCs that we have within our unit. I'll briefly explain what each one does. The FFBH 4-5 is our mental health UTC. They provide nurse support for psychiatric triage and assessment. They also provide prevention and outreach services. The FFP-MRN is our bioenvironmental engineering and public health within our unit. They provide disease prevention and control. We have our 9AF S2, or our first sergeant, and they provide general supervision for all enlisted personnel. They are the focal point within our unit for all matters concerning enlisted members, and they ensure that our members understand our policies, goals, and objectives for our unit. The FFDDR, or our Drug Demand Reduction Program, promotes mission readiness and deter, defect, and prevent illegal and illicit drug use. They are the ones that run our urinalysis program. FFLG1 is our medical logistics support, and they provide us logistical support to theater hospitals and other operations. TFRR8 is our education and training section. They provide follow-on education training. They give the base resources and library services, as well as testing, tuition assistance, and other educational resources. The FFCMD is our commander. Our commander provides medical command for enduring medical operations. 6K DA5 is our admin. They provide administrative, human resources, executive and postal mail support for commanders and other elements at any level. Here are some of our aerospace medicine UTCs. The aerospace medicine UTCs generate in-place support of the parent wing and/or provide personnel augmentation to a fixed medical treatment facility in support of a base population. The FFDAF and the FFDAG provide flight medical support and medical manpower to accomplish physical exams and medical readiness for 500 AFRC wing personnel. The FFABC provides 24-hour sick call to mobilized non-co-located AFRC wings supporting up to 1,000 personnel. The FFDAF and FFDAG UTCs are what we have in our ASTS unit, and that's what we're doing on drill weekends, is when we're seeing members from across the wing and even in our own unit, making sure that they're green and good to go for deployment. The FFABC, or the 24-hour sick call, we don't have that on base, but we have the capability to do so in a mobilized location if needed. This is the last group of UTCs that we'll talk about, and it's the APES UTCs. Our FFPPS UTCs are our clinical providers, additional nursing staff, and medical logistics personnel. We all serve as clinical providers and interface capability within the aeromedical evacuation, or AE system, forward care, major theater war, and humanitarian assistance disaster response. This is where we get into the APES or ERPS mission. The capabilities for the ERPS mission is to be able to provide manpower for 24-hour operations of 10, 50, or 100-bed evacuation squadrons. We provide medical care and support for our patients, and we prepare and make sure the patients are ready for flight. What is the ERPS? The ERPS is the en route patient staging facility. It's a 10, 50, or 100-bed facility. It consists of nurses, medical technicians, and medical admins. It administratively and medically prepares patients for flight and ensures that patients are clinically supported while in the facility. They also transport patients to and from the aircraft. APES is the training that is intended for people who are tasked in the ERPS UTC. This chart here is really good at showing the continuation of care from the moment that the soldier is hurt or sick to getting to a CONUS Care MTF. And I just kind of want to show you where the ERPS falls under that. So it starts off here where I highlighted with the injured soldier. They go to the first responder or self-aid buddy care and get their initial treatment. They might be forwarded to an EMEDS, which is just a smaller, very basic care, getting people stabilized. They're not intended to stay there for probably more than 24 hours. And from there, they're going to get sent to theater hospitalization, typically in ERPS. So in Qatar, we were in ERPS 50, and the patients were staying with us for 24 to 72 hours. We just take care of them and hold them until they have a flight to get to a CONUS MTF or hospital. The ERPS 100 is a 23-person UTC and is used as a bed extension and augmentation package for the ERPS facilities. This UTC can do everything the ERPS 50 can do, but with up to 100 beds and 100 patients during a period of 72 hours. The ERPS 50 UTC is FFFPS. This is what we were in Qatar in ERPS 50. It's exactly like it explains on the slide. Our mission was to track our patients, pick them up from the aircraft, provide a place for them to receive the care that they needed, and for them to be cleared for flight to go to Germany or other CONUS hospitals for further treatment. It says here that they should stay only up to 72 hours, but there are many times where the stay would be almost up to a week. You can't know or control when you're going to get a flight out for your patients. Our facility had 26 beds, and we were supposed to be expandable to 50 beds, which would end up being cots after the 26 beds were taken up. We were technically a hub for equipment as well. Some patients would come requiring certain equipment like an IVAC or a heart monitor, and they didn't always come with it from their locations, so we had to be able to provide that for them. We had a medical logistics team, and that's the FFLG1 UTC that we talked about earlier, and they were the ones that we had to be in constant contact with to make sure we were getting the resupply of what we needed. There were times when the flight crew would also request certain items that they needed for possible patients they were picking up on the way to Germany, so we supported many patients that we never even came into contact with. The thing that we had to learn quickly was flexibility and being able to provide when we were asked to. The ERPS 10 UTC is the FFEPS. They also fall under the ERPS 50 UTC. On deployment, we had 13 medics, nurses, and administrative personnel who were ready to be forward deployed as the ERPS 10 team from the ERPS 50 team. The ERPS 50 would have been able to sustain the requirements for the ERPS 50 without them if needed. The ERPS 10 personnel had the same training as the ERPS 50, and then some. They had Fieldcraft Hostile Environment training, and they also had their trainings on how to set up their tent and pack up their vehicles to be forward deployed if the time came for them to do so. They would have been in a mobile or fixed 10-bed capability tent or facility that provided rapid response patient staging of 10 patients at a time, a maximum flow of 40 patients in a 24-hour period, and a maximum 6-hour patient hold time. The team would have been able to sustain this tempo for 72 hours without augmentation. Some planning factors for ERPS are things such as having food, water, shelter, sanitation, security, fuel, and electricity available. And also for the ERPS 50 and ERPS 100, having BMET around or equipment maintenance, because both of those locations are going to be a hub for equipment, and they need to make sure that they have people there that can fix equipment if needed. It's intended to be located near a medical treatment facility. It's designed for short-term medical surgical nursing care, but not critical care. It's usually located at an aeromedical evacuation hub, and there's no surgical, lab, radiology, dental, mental health, or blood bank. There are some unique cases though, like in Qatar, we had all of those things. We had surgery, we had lab, we had radiology, dental, mental health, and a blood bank. That was just a special thing for Qatar because we're directly attached to a medical treatment facility. Qatar is just a more established area, so we had all those things available for our patients if we needed it. but typically the ERPS wasn't receiving patients that really needed surgery or needed labs done or things like that, because by the time they get to us, they're pretty stable, or they don't need care necessarily with us. Their care could continue in Germany, where it can be with the same doctors, same medical team, stuff like that. One very important UTC that we have in our unit is the Critical Care Air Transport Team, or the CCAT team. It's a 3-person UTC. It's the FFCCT. It consists of a critical care physician, a critical care nurse, and a respiratory therapist. They're a supplement to an AE crew for high acuity patients. They provide advanced medical care to critical patients during flight. They can transport up to 6 patients. They operate on multiple platforms, and they are the international benchmark for safe ICU level patient movement. So I know I said that most patients are stabilized in that eMeds tent or the very first place they go to for their very basic care, and sometimes they are, but of course we know that there are people that get very severely injured where they are going to be ICU level patients, and they need to be transported to get further help all the way into a bigger hospital. And that's why the CCAT team is here, because they are one sole team that are specific just for those patients, and they're going to be the only patients they focus on. This slide just breaks down everything we talked about prior about the different ERPS levels, how many beds for each one, the types of people that are involved in each. So this is just a good visual if you wanted some more explanation on how that looks. Thank you everybody for watching and listening. I know it's kind of a lot of stuff to talk about, especially virtually. It would be a lot easier if we could all do this in person, and maybe we will once we're all able to be back together in the same room so we can answer questions and have more of the deployers actually talk about what it was like out on deployment. But I appreciate everybody's time, and I hope everybody's staying happy and healthy and safe, and hopefully I'll see you soon.